Good morning, and good morning. We are here with the fabulous Elizabeth Snelgrove Arauz, who is one of my clinical directors at Triad Psych. And this is a getting to know you video for if you're considering our practice for any type of need you have. This is a good way for you to get to know us a little better. So Elizabeth, not only is she a clinician and a therapist, a licensed clinical social worker, she also does expert witness testimony very effectively, I might add, especially in cases involving LGBTQ plus children. And as well, she is trained in somatic therapies, which is now very effective for healing trauma. So without any further ado, I'm going to ask her these rugged questions so you people out there in YouTube land can decide if it's a fair or not. So Elizabeth, why did you become a clinician and a therapist in the first place? Why would you want to do this? Why in your right mind have you do something for this field?
Well, hello, Dave. Thank you for the intro. I appreciate that. Why I became a therapist? Well, I have been a therapist since I was born, essentially. Prior to actually joining the practice and doing my social work master's degree program, I was a paralegal for about 12 years, which included a lot of therapy. And then I had 3 children and decided that it was time to go back to school and actually follow my passion, which was the counseling piece of what I did. And so that landed me here.
Right. And you were at a hospice before Triad picked you up. Let's talk about your hospice work a little bit.
Yes, I did about 2.5 years or so working in hospice as a social worker. And that time included, being there for families and doing end of life planning, which is incredibly difficult for them and was an honor for me to do, to, hold the hands of these individuals during this really hard time.
Well, that's a very special skill set. It takes a very particular kind of person. That's an aspect of your work we've never really broadcast at Triad, but of course you still have the skill set to do that. So that's another thing to think about, is that if you are dealing with end of life care, I've counseled a few people in my career, and I found it who are end of life, and I found it to be very rewarding, challenging, very challenging, and you have to be their ego and help them guide through something that's very scary, but it's very rewarding work and can be very effective too.
And something on top of that too is during my time with hospice, it was also during COVID. So that was another layer of everyone else is, locked down, and I'm out in the field, meeting these people face to face, and just had to get it done and be there for them.
Marvelous. That's excellent. Well, we appreciate that. I'm sure they appreciated that very much.
Thank you.
Coming into Triad, you didn't have much of a neurodiversity background coming in, so I trained you in the Triad system, which can be used for anything, but was originally designed to work with neurodiversity. Yes. And then you picked up on it very quickly. And then we found out you came in with another specialty, which is LGBTQ.
Yes.
Which we found out that the crossover between neurodiversity and LGBTQ, gender confusion and the such, is very, very strong. Let's talk about that a little bit.
Yeah, so in my grad school studies, I actually devoted my time to researching gender dysphoria, the why, the what, the how do we help these people. And honestly, it wasn't until I joined Triad Psych that I really began to see the crossover between gender dysphoria and autism, which then, prompted me to do a lot more research about that specific topic. And it's a phenomenon. And it's something that needs a lot more research, but I'm absolutely finding about 90% of my patients who struggle with gender dysphoria symptoms are also on the spectrum. So it's looking from my end and the research end like it's more of a neurological divergence as well.
You mean the gender the gender confusion.
Yes.
Yeah, right. And I believe, and this isn't something I've worked very much with, that this rose up. I had my hands full, still have my hands full with my specializations in my practice. So I just delegate these cases to you. But from what I do know, the American Academy of Pediatrics does feel it's neurologically rooted.
Yes.
So can you talk a little more about that?
The research, again, it's still in a baby stage, I guess you could say. But oftentimes, as we know, with autism, we can have very fixed thoughts, and have difficulty kind of veering outside of, their thought patterns into what is considered in the box thinking, right? Which is what everyone else lives with.
Yeah, I wouldn't know anything about that, but yeah.
Right. But these individuals are finding that not only are they struggling socially and emotionally with the symptoms of autism, but then there's a whole gender aspect that is confusing and scary. And, we're trying to understand why that happens and why it's not a choice. It's something that you're born into. And on that note, it's very, very difficult for the families because people don't understand it. They don't understand. They think it's a choice. And we're finding that those kids and adults even who aren't receiving the support and the guidance they need from families, it's leading to depression, suicide, substance abuse, the whole gamut.
And now we have a male clinician in Marietta who also deals with this, John Mark Parker, who'll get his own YouTube interview soon. But you were here first. At our clinic, you dictate policy and clinical protocols regarding these patients as well, I should add.
Right. And on top of that, just our clinical work here, we also have to factor in the political climate that we're in, which is targeting these individuals in a way that is exacerbating the symptoms that they already have. And so that's just another layer of what we're having to manage. And it's different from state to state. And the laws change.
Not speaking as a clinician, but as a social worker.
Yes.
How do you better mitigate or navigate this political climate right now?
Absolutely.
Now, as a social worker, how do you, there's a clinical piece to what we do, but for you and I, how do you mitigate it as a social worker, from a social worker point of view, as to how these usually adolescents navigate different systems?
Essentially, it's being on top of and understanding the laws as they're changing, and specifically what laws are happening in what state. So if there are particular laws that are now prohibiting individuals to seek gender affirming care in Georgia, then I'm looking elsewhere. What other states, what neighboring states have a more, soft approach to individuals dealing with these sorts of symptoms? So then I go a step further and find out, okay, what can these families get out of state that are still legal to come into the state of Georgia? So it's, doing the micro level and the macro level of research.
Advocacy too.
Yeah, to truly and advocate for these people who deserve care and need it.
I think it's also important we talk about what we don't do at Triad with these cases, that we are not a surgery clinic. We do not prescribe medicines, hormones.
No.
And no matter where people feel on this very heated debate now around LGBTQ+, is that no one is condemning the work we do, either conservative or liberal. That what they're saying is counseling first, counseling, and that's what we do, is the counseling. Do you feel that there are some elements who are kind of quick to jump the gun if a teenager's having some confusion to go ahead and initiate surgery or initiate medicine?
Absolutely. And that is why we go by the gold standard of care, presented by the World Professional Association of Transgender Health, which is to use the gender affirmation model. And what that model is, it's not a push or a pull when it comes to therapy and interventions. It's about waiting and letting these kids and people talk and figure out who they are. And through talk therapy, understand, what are these symptoms that I'm having and how can we alleviate them in the immediate without jumping to, an actual permanent intervention.
Yeah, there's no reversing that, or it's very difficult once it's done. And I think everyone needs someone to talk to. And
right.
The influences, there's so many, not just kids, but adults, they're getting all their information from Dr. Google, not from us. And that's creating problems no matter where or how you're practicing. Well, I read on the internet this, I read on the internet that. But
And that's why there's a very stringent screening process. I do a lot of understanding, where did these thoughts come from? And if they can identify it, oftentimes for the younger kids, it is on social media, and so we have to be realistic about that while also supporting them. So it's a slow process, it's a very slow process. And it isn't until we've worked for many, many months, if not a year, before I'm sending referrals for them to see a medical doctor, to then be assessed by the medical doctor to see if that's something that, that we can work with as a treatment team.
have you ever seen adolescents face peer pressure to go in one direction or another?
Absolutely. I think we see peer pressure with many mental health diagnoses these days. I have many kids coming in asking me for a diagnosis of borderline personality disorder.
They're asking for that?
Yeah.
I didn't know that. That's news to me.
Yeah. Asking for autism diagnoses, asking for all kinds of things. And so my job is to figure out why. Why do you need this? Why do you want this?
I've been in the neurodiversity space for over 30 years. And, when I first got involved in the field, everyone was fighting not to have that label. Now we've got people dying to get it. It's amazing how things change, and from 1993 till now.
Well, and I think a lot of the issue comes from, honestly, COVID. So many of these kids were new to school when COVID was going on. And so communication skills aren't what they used to be. And so they spend so much time online, that it can distort reality, because if you're not living out in the world, you're living in this little tunneled vision of the internet. And so it's just helping them understand. And I think a lot of kids are claiming it because it's almost like the end thing. They all have something that, a common ground. It's just often misled.
There's another tie in there to our clinic's philosophy and how we work, is that we've been here for 23 years now, that I always made it clear that we'll never be a clinic that hops on trends, that we will study trends very, very closely, but we're not going to blindly hop on trends. And I think that's happening a lot in our society, not just in mental health, but in the way I was trained was, you study a trend first to see if it's valid. Is there evidence to back it up? Then make a decision as to what to do. So we don't hop on trends. We think things out, and we encourage all of our patients to be very self-directed, not followers, but leaders, no matter what they're coming in for. Okay, so now you recently got a certification in somatic therapy. I really don't know what that. I mean, I do know what it is. I don't know how you do it. It seems to be overlapped with some yoga, where you come in very relaxed and refreshed. I come in to work very agitated. So I probably should sign up for it. But why don't you tell us a little more about it?
Well, it's funny, when I first started going into yoga, it was definitely for me. It was my own self-care. And my yoga instructor happens to also be a somatic practitioner. She's an expert. And so I decided to take her 100-hour certification. And I learned so much about, the nervous system and how little control we have over that. Right. So somatic yoga, it focuses on the sensations in the body, sensations that maybe weren't before recognized. So trauma, depression, all of these heavy symptoms, they lay dormant in the body. And so what we do is start to use breath work and identifying where in the body you might be feeling stress or strain. Right. And by identifying that, I then have them work through a process of, what does it look like? What does it feel like? How heavy is it? What is it doing for you? And it's interesting. Last week I had a session with someone doing that very practice, and she's like, it's in my chest. It's strong. It's heavy. I'm like, well, hold it. What does it look like? She's holding this thing.
Don't run from it either.
Don't run from it. Well, that's the thing. And I said, what does it look like? And they said, it's like a ball, maybe sun, but it's covered by fog. I'm like, okay, well, what's that fog? It's like, I don't know what that fog is. Okay, what's behind that fog? It's a sun. Is it? Okay, what is that sun? Well, as we spoke, she recognized that sun inside of her was a feeling she had with a former partner. And that fog over it was is she still there? Is that feeling still there? We don't know. So I said, blow the fog off. What happens if you blow the fog off? Well, I'm afraid there won't be anything there. It's like, okay, well, what would have been there? Well, this person would have been there. So why don't we blow the fog? Because I don't want to find out.
Wow.
Yeah.
Oh, that is heavy. I mean, we're talking about not hopping on trends, but a trend I'm seeing coming up that I think is a really good one is we're training clinicians to walk with patients through their symptoms rather than just trying to extinguish them. That I got certified in the assist model of suicide prevention a couple of years ago. And, we were always trained if a patient's suicidal, okay, well, you do these very rigid steps. You bing, 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 you contract for safety. You find out if there's a loved one around. Do they have a means? Do they have a plan? Whereas the assist model actually instructs us not to react, to sit there with them and actually go through with them. So if you were to do this thing, take your own life, what would it really accomplish?
Sure.
And to sit there, and what you're doing is what you're talking about, is that you're walking through it with them, doing it around, and that breaks down, because we know that when people are suicidal, they're highly ambivalent about what to do. They're back, do I do this? Sure. But it breaks down the intensity of it. It gives them a better framework, and it's a diffusing effect that it opens up. And there's an organization called the National Organization of Victims Assistance, and they were the first ones, I think, to really talk about somatic treatment for trauma. And it was very different from mainline models, especially the ones I received, going into police psychology as well, that we were much more, bring interventions to bear. It was a police department, though, that rolled out the assist training for me. So we do see things changing there. Okay. Excellent.
Well, and with the somatic therapy, it's very much inclusive of the breath work, using our breath to, kind of move through these heavy symptoms and kind of ground you. It's scientifically proven that mindfulness breath work brings down your heart rate, brings down blood pressure. And when you think about it, so many times we hold our breath.
Oh, yeah.
When we're in trauma, and I've said in sessions sometimes, like, breathe, take a breath. Our bodies can live, I think, 3 to 5 weeks without food, about 3 to 5 days without water, but only about 3 to 5 minutes without air.
Right. And we know that with panic attacks, that usually the person's breathing has gotten somewhat impaired or constricted about 45 minutes before the attack happens. So it can also be a build-up process as well. That, when I had patients who had panic attacks, I would get them to go do very intense cardiovascular exercise before heading into the environment where the panic was occurring. And for some strange reason, it just didn't happen because you said the breath, the air is already moving at a better pace and going through there. That's great. And we'll be integrating a lot of that. And we know that people who are neurodivergent are essentially born to be hypervigilant, almost born with PTSD.
Right.
So it's another big crossover there, I'm sure. Okay, last but not least, let's talk about your expert witness work that you've been doing very well with lately.
Well, with the expert witness work I'm doing, because I specialize in working with individuals whom identify as LGBTQ and specifically trans, it's a highly sought out and a very sparse availability, to people. And it also includes my expert witness work also includes children who are going through some pretty intense situations. But I've had some very successful wins in the courtroom by presenting the truth, evidence-based information and honesty. And it's helped. It's making better lives for these individuals. And I love it. It's a new passion of mine.
It's also, because we both do that work, I do a lot of custody work too, is that when a family is stuck in this tunnel of the family law system, that does more damage than a divorce per se. So by coming in and providing really evidence-based information, we can get the family unstuck. We give the judge a roadmap. When I went into the expert space, that I noticed a lot of experts were getting on the stand and just putting information out there like logs floating on a stream,
Right.
and letting the courts maybe pick and choose what they want or don't want, but not planting a very defined flag. We don't do that. We provide, look, this is what we see happening, and this is how fast it should happen as well.
True. And it takes away the blame game. One parent, accusing the other one of this or that. It's like, no, it's much more than that. So
yeah, we're more than happy to take the blame if we have to. So that's well,
right.
The experts said it. Okay, well, this was excellent. I'll let you get on with your day. Thank you so much, Elizabeth. And if you're out there watching in YouTube land, we hope you found this to be informative as well. Thank you so much.
Thank you. Bye, Dave.
Bye-bye.